Welcome to ISELP In Motion, the official podcast of the International Society of Equine Locomotor Pathology. We bring you conversations with leaders shaping the future of equine sports medicine. At ISELP, we're dedicated to advancing education and improving outcomes through collaboration and innovation. Today's guest is one of the true pioneers in equine rehabilitation, Dr. Steve Adair. Steve is widely recognized for his work in advancing rehabilitation as a specialty and for establishing one of the premier equine rehabilitation programs at University of Tennessee. In recognition of his impact as a mentor, scholar, practitioner, and industry leader, the Adair Fund has been established to support equine sports medicine, rehabilitation, and future research. Over a 4-year career, sorry, you wish it was a 4-year career.
I wish it was just 4.
Over a 4-decade career, Steve has performed inductions on reticulated giraffes, exploratory surgeries on polar bears, surgeries on rhinoceroses and elephants. He has also served as health consultant for the Anheuser-Busch Budweiser Clydesdales. Yet he often says his most meaningful experiences have been working with students, interns, and residents. Steve, welcome.
Thank you for having me, Kent. Certainly appreciate it.
Yeah, well, tell me, you've had some fascinating different things you've done, wide varieties. Tell us a little bit about your journey to veterinary medicine and then some of the incredible experiences you've had.
Well, it goes way back. Of course, my father was a veterinarian, so I've pretty much been in veterinary medicine all my life. And, but yet, I started out actually playing baseball, college baseball, but soon realized that, I wasn't going to make any money doing that. So, went through some trials and tribulations, looked at med school, looked at dental school, and then actually came back and decided to become a veterinarian. Played a lot in undergraduate, and so consequently had to get my master's in order to get my grades up. But got into vet school and thoroughly enjoyed vet school. Was going to be a small animal vet and go back and work with my father. And then second year was going to be an exotic vet. And third year I started working in a large animal clinic and actually fell in love working with horses. And so pretty much that's what I did. Went to private practice for a couple of years and got tired of digging out hoof abscesses and tube worming horses, and so there was a ad came up in the AVMA journal for a large animal surgery residency at UT. My mentor, Dallas Goebel, I called him up and said, Dr. Goebel, I'm interested in this position. And he said, well, if you're going to come visit, he said, you better come up this week. He said, because we're going to make a decision next week. So I drove up from Lake Charles, Louisiana, and I visited and then turned around, drove back to Lake Charles, Louisiana, because I went back on emergency duty on Sunday. So I visited on a Friday, went back on emergency duty on Sunday. So they called me up a week later and offered me the position. What's funny is I took a pay cut. Back in the mid-'80s, I mean, my salary in practice was $18,000. And to go back and do a residency, I dropped down to $14,500. And so that just shows you the differential that we have nowadays, because most of our residencies are going, 35, 40, 50,000, kind of in that range, depending on where you're at. So, did my residency in large animal surgery. Well, actually, I'm boarded in veterinary surgery because I did as much small animal as I did large animal. And nowadays, they differentiate or they divide up small animal, large animal, and then equine. But mine was across the board. So
Wow.
got boarded, and at the time they needed somebody to run the farm animal clinic. So for 2 years, I ran the farm animal clinic at UT. And then they decided they wanted a full-time surgeon, so I transitioned over and strictly did surgery, and that's where I started doing a bunch of stuff. The first reticulated draft that we actually published, knocking it down 7 times, which was a record. I actually fixed a broken leg in it, so I was involved. I did the surgery and fixed it. Worked on another reticulated giraffe, taken out, had a broken jaw, put it back together, took out P3 on an elephant, actually 2 elephants, fixed pate neurachus on a rhinoceros, exploratory on polar bears, and all of this became, the reason for it is UT has a very strong exotic department. And so at the time we did, the large animal clinic did a lot of their hoof stock surgeries and stuff like that. So that kind of got me involved in that aspect, in addition to just our routine, equine surgery caseload, colics, broken legs, arthroscopies, and stuff like that. So, it's early on. I made most of my research was in laminitis, and so I did a pretty fair amount with laminitis research, but got tired of foundering horses, and so actually recognized early 2000s there was more to surgery than just the surgery, and that kind of got me interested in the rehab part, and the rest is pretty much history. Started working on the rehab early 2000s. Developed a certificate course in equine rehabilitation. The first one was offered in 2005, and it's been going on since that time. We opened up the Equine Performance Center in 2013. And so it's a dedicated performance medicine and rehab facility. Became a chartered diplomate of the American College of Veterinary Sports Medicine and Rehab about 2011, 2012. Had my first resident in 2015. So, it just kind of blossomed from there. My mentor, Dallas Goebel, UT started the herd health consultant program with Anheuser-Busch in 1982. And I took it over from Dallas Goebel 2011, 2012, still do it. I fly all over the states looking at Clydesdales, and basically if anything goes wrong with them on the road, I get contacted, and we talk about what to do, and I really enjoy that aspect of it. So continually, we had a couple of sick ones last week I was on the phone about. So other than that, a lot of teaching, a lot of students, started teaching residents and interns. Well, I started teaching students in 86. And once I became boarded, started teaching residents in 93. And so really that's been probably the more satisfying aspect is the teaching aspect, of students. It's very rewarding to take a young mind, be it a student, be it an intern, be it a resident, and see it develop, and how they progress over time, and to try to impart a little bit of my knowledge. and maybe more practicality. I mean, I always tell the students, it says on the bottom of your diploma, no matter how hard you try, you can't kill them all. And it's it's and I also tell them, and I use myself as an example. I mean, it's my first year in vet school. I went on academic probation. I hated anatomy and I hated histology. But then afterwards, when I hit my sophomore year at Auburn, that's when everything clicked. And from there on out, I mean, it was pretty much a piece of cake. But my first year, it was tough. And I tell students, I said, listen, you know what they call the last person in the class? They call them doctor. I said, so, you just because you don't have to have straight A's. And in fact, if you're a straight A student, oftentimes you're not a well-rounded person. And so you need to take some time for yourself. You need to enjoy life. There's more to life than just school. So don't tunnel vision down on school. Yes, it's important, but save some time for yourself. So that's kind of my history overall. Just recently retired. I actually retired July.
Really?
Still, yeah. So I'm out of the clinics now. I still go up there. I've got a squatter's desk that Dr. Ursini has made for me in her office. We're working on a new book on large animal rehab, not just equine, but all species. Because at UT, we do goats, we do sheep, we do camelids, we do cattle, pigs, horses. So we kind of do a little bit of everything as far as rehabilitation goes. So I still go up there, still teach my rehab course through the university, and of course still do the Budweiser Clydesdale. So I stay active. It's just I don't have to do any committee work.
Well, I'm sure you miss that.
Oh yeah. Miss the committee work for sure. But I do miss the teaching. I do miss the interaction with students, but in residents and interns. But otherwise, that's pretty much it.
Well, that's an amazing career there you're describing. And, my father was a veterinarian as well, and equine veterinarian, and went on to do. He had a PhD additionally, and so he developed xylazine.
Oh, cool.
For Camagro. And so, and it's still one of the most common drugs we use in the clinic every day. And and I get, you get an intern or a fellow, and they'll go, oh, well, we'll go give that horse detomidine. And I go, look, we're just doing a short procedure on the horse. Let's just use xylazine, and the client can actually get their horse in a trailer and safely drive home. There's no reason to give it detomidine. We don't need that long. And they're just, again, that's one of those tremendous tools that has been around for a long time. And it's always interesting to see the history, and then it's interesting to see how some of the students just aren't really very aware of that particular alpha agonist.
I know it.
They're onto the new ones.
Yeah, and it's and I see it. I saw it up at the university. I mean, first thing, interns and or residents coming in, first thing they want to pull up is 0.3 of a cc, a half cc of detomidine. And, whereas you could give them a cc and a half of xylazine and pretty much do the same thing. So, it's amazing how ingrained something gets, and it just becomes habit and sometimes, again, as I had mentioned, tunnel vision, and it's, it's good to teach them another way to do things, for sure.
Yeah, absolutely. Now, so your rehab center there at University of Tennessee, that was finished in when?
Well, we opened in 13.
13.
We actually went through an entire remodel, just because it's no secret. The large UT went on limited accreditation from AVMA, and it was basically due to facilities.
Yeah.
And so part of that was the large animal facility. So in 2008, we made a push for expansion and remodeling of the large animals. So through a combination of state support and private donations, came up with the money to do the renovation and expansion. And as part of it, Small Animal already had a canine rehabilitation program going on. And I had been doing rehab on the surgery service since 2005. And so we kind of made a push. We wanted to develop a separate building. It's connected but separated by a breezeway. And so it is actually a fully self-contained facility. So we decided we wanted to go down that route. And it's certainly, we call it the EPRC, Equine Performance and Rehabilitation Center. It's a little bit of a pet peeve of mine. The sports medicine, sports medicine infers athletic endeavors, where, this could be a backyard horse that needs to be rehabilitated. It doesn't necessarily have to be an athlete. And so I like the term performance. So that's why it's the EPRC, which is Equine Performance and Rehabilitation Center, because we want to cast a more global net and bring in those backyard horses, bring in those pleasure horses, and not have to specifically be an athlete. Some of these horses, all we've got to do is get them to where they can walk around the pasture, but yet they do need some kind of rehab. And so, and there's, nowadays people think a lot of their horses as pets, they're companions. And so they're certainly willing to do what it takes to bring this horse back to a useful and relatively pain-free life, So, and that may be walking around pasture. But
and you never know. And the clients will sit there sometimes and they'll say, well, we're not going to do all that much with him. And I said, okay, well, he's lame. Are you going to trot? And they go, yeah. Well, then we need to rehabilitate him. Yeah. And I said, it doesn't really matter what their job is. They can be pony club pony. They can be an Olympic eventing horse. Mm-hmm. If they're going to do something athletic, you have to rehabilitate the horse from the injury back into the work. And you're saying he doesn't have to do too much, doesn't really change the fact that your horse is currently limping and we need to make it not limp.
Sure. Well, the other thing is, and I'll use colics as an example. You can have post-operative colic that can really benefit from a rehabilitation. You think of that linea alba incision, and maybe this is going to be nothing more than a broodmare, but yet you need to have that linea alba as strong as it potentially can to carry a foal. It's the surgeon mentality of mine early on was, okay, 30 days in a stall, 30 days in a paddock, and 30 days kicked out to pasture, and don't do anything with them for 90 days. And we know nowadays that that's really not a proper thing to do. That we take it, and that's one thing we do at UT is we're probably more aligned from a rehab standpoint with human physical therapy than we are animal physical therapy. We do a lot with therapeutic exercise and that type of situation. I mean, I've been through rehab on my knee, I've been through rehab on my shoulder, and yeah, they do use some modalities, but a lot of it is exercise related and controlled exercise and specific exercises to strengthen various parts. We do prehabilitation. We take bulls that are coming in for cruciate surgery, and we do work with E-stem and muscle strengthening on bulls to strengthen that muscle around the stifle to prepare them for cruciate surgery. So we do the same thing with horses, and that's called prehabilitation. So there's a whole gamut, that goes from prior to surgery to the immediate postoperative to the rehabilitative period long term. So
yeah, and I know, you even talk about something as simple as, upward fixation of the patella. And that's one where, you and I go far enough back that, back when that happened, well, gosh, you just cut the medial patellar ligament and you move on. Well, then we learned, most of them did okay, but some of them did not. And then we were, of course, destabilizing the patellar joint when we did that. And you think now, particularly those of us who have gone through human medicine and had, say, a total knee or a significant knee surgery, that prehabilitation, that working on the quadriceps so that quadriceps is toned, and because you're going to lose muscle mass after the surgery, so what can you do beforehand? And then the more I thought about that, I thought, well, geez, why do so we're still doing some form of surgery where, we're doing something where we're thickening the medial patellar ligament. And why don't we just work more on conditioning the quadriceps? That's easier to do. We can do it. We can teach the client to do it. It's not like if all these surgeries we did were 100%, well, then it's like, why bother with this other stuff? But they're not.
Exactly. It's, there's certainly those exercises and techniques that you can use to strengthen that muscle, the quadriceps and vastus and whatever around the stifle. The same thing. I mean, I'll be honest with you, proximal rear suspensory desmitis. I used to do surgery. In fact, Jim Schumacher, Ferenc Toth, myself, I'm on that paper. We developed a neurectomy, deep branch of lateral plantar nerve neurectomy for these cases. And I mean, heck, I can't tell you how many nerves I cut. But then when I got into the rehab, I got to thinking about it, and I have found that my success rate using orthobiologics, regenerative medicine, and rehab pretty much equaled what results we were getting with surgery, So, I mean, surgery is only about 75% effective at best, and you still have to go through a rehab program. And I just found that using orthobiologics and putting them in the rehab, I'm up there around 70%, 75%. So, it's certainly, I do reserve surgery. There are going to be those cases that don't respond to rehab, and you'll have to go in and split the medial patellar ligament, or you'll do a neurectomy or fasciotomy or whatever the case may be. But at least I give the rehab a chance. Same thing with backs. There's a lot of things that can be done for overriding dorsal spinous processes, kissing spines from a rehab standpoint that you don't have to go in and do surgery. And, so we tend to take a more conservative approach and look at rehab first. And then if we don't have the desired outcome, then sure, we'll progress to surgery. I still like to cut, but.
Yeah, no, I think the key on that is, like proximal suspensories, we did a paper comparing surgery. Back then it was the fasciotomy, now the neurectomy, of course, more in style. But, what we saw was both of them wound up in a range of between 60 and 70%, whether we did shockwave or whether we did surgery. The difference was that the rehab period was shorter on the shockwave than if you cut them. And if you cut that fascia, that takes time to heal. There's a lot of inflammatory change in there.
Well, think about it. When you go in there cutting that tissue, you're causing trauma. And so you get scar tissue, you get adhesions, and that's oftentimes the reason for failure is that you don't address those post-operative events that occur from inflammation, from scarring, from adhesions, etc. So yeah, I totally agree. It's as much as, and surgery is my first love. Don't get me wrong. I love to cut. In fact, I always tell the students, and I tell the medicine residents, a chance to cut's a chance to cure, type situation. But it's surgery's trauma, and you have to recognize that and address and realize that you need to address that.
Did you ever see my little saying I had that absent a diagnosis? At the top, it says absent a diagnosis, and then it says surgery is trauma, medicine is poison, alternative therapy is witchcraft, and rehabilitation is a waste of time.
That's funny.
You got to diagnose it first.
Got to diagnose it first. If you don't have an accurate diagnosis, then, it doesn't matter what you do. I mean, you do treat the whole body, but you do have to address the underlying or the primary cause for sure. Yeah,
it's, and it's so frustrating. There's all this good work done in rehabilitation nowadays, and we've got so much more science than we had 20, 30 years ago.
Sure.
But if, I saw a case come in and it came back in because it had been in rehab for 6 months at a facility. And it shows up, and I say, okay, what's the diagnosis? Well, this is the diagnosis. And I go back through and I go, well, fascinating, but that's not the diagnosis. And so it had the wrong therapy for 6 months, and because it was given the wrong diagnosis originally.
Oh, and my goodness.
It's like, it's not rehab's fault, but it's you got to get the diagnosis right.
You got to get the diagnosis right, for sure. Yeah. You got to know what you're rehabbing. You got to know what you're treating, for sure.
So now, like I say, and what we're talking about is that rehabilitation has become a specialty now, and it clearly, it has evolved tremendously over the years in what tools are used, what, it used to be all there was whatever you told the rider to go do with the horse after the procedure or whatever. And then they were going to go do that, and then you would recheck it. And the question was how often you rechecked it. Now there's the option to go into rehab facilities and use these specific tools.
Right.
So my question for you is, okay, those tools exist. Now we looking at before and after. Before, I rehabbed a lot of horses from proximal suspensory ligament desmitis without anything more than the rider ride walking the horse and me rechecking it monthly and eventually moving on into a work program. Now there are water treadmills and, pressure devices you can put on limbs and all this. So what's really needed? I think that's a hard question to answer, but it's one that practitioners driving around in trucks or at clinics are constant. Yeah, there's that facility, but do they really need it?
Do they really need it? I think the first thing you have to decide, I would say yes, it is needed, but not every modality. I'll be honest with you. It's I use the KISS principle, which is basically keep it simple, stupid type situation, and not every case needs laser, shockwave, therapeutic ultrasound, radio frequency therapy, yada, yada, yada. Again, go back to what you did. A lot of times therapeutic shoeing and a controlled exercise program that targets very specific areas may be all that's needed. I'll be honest with you. If from an underwater treadmill, I'm going to throw this out there. If you look at underwater treadmill, what are you trying to accomplish with the underwater treadmill? Well, range of joint motion, decreased weight bearing, buoyancy, and resistance to movement. And so I'll be very honest with you. If the only thing I'm looking at is range of joint motion, heck, I can take them and walk them over poles and cavalettis and accomplish the same thing than a $200,000 treadmill, underwater treadmill. And so I look at the underwater treadmill more for buoyancy and resistance, in the rehab process. Once you reach the level of the carpus and the tarsus, you've pretty much reached maximum joint motion, thereabouts, maybe mid-forearm and the gaskin. But you really don't have much resistance. You have no buoyancy. So at that point in time, with water up to mid-forearm and mid-gaskin level, really all you're doing is working joint motion. And so, like I said, I can go do poles. So I'm a fan of high water, and don't get me wrong, it depends on what you're rehabbing too. So there's a whole different spectrum as far as selecting stuff. But we tend to we design programs based on the individual, and we will actually adjust that program on the fly. One day I may say, well, I worked this horse a little bit harder than what I needed to. I'm going to back off on the exercise, and I'm going to throw laser in, for its anti-inflammatory effect. Or maybe I've done some regenerative injections, and I'm going to throw laser in for 2 or 3 days, trying to stimulate stem cells. Maybe I throw them into hyperbarics. We did a paper several years ago that we shown that hyperbarics will stimulate circulating stem cells or increase the number of circulating stem cells. So maybe I pre-treat with hyperbarics for a day or two and do my regenerative and treat. it's not a one size fits all.
Right.
And that is what I encounter a lot is everybody wants a recipe. Everybody wants a protocol. And we can give very general protocols, but you have to be willing to adapt on the fly or change on the fly. And I'll be honest with you, rehab's hard work if you're going to do it properly. Rehab's hard work. Most of our patients in the rehab center, they get hands-on interaction about 4 hours a day. You know, that starts out with stretching and maybe balance pads while they're eating their breakfast. Then they move on to the underwater treadmill. Then they eat lunch. Then they start out arena work over the poles, whatever, and then they end up with in the free walker as a final exercise. So they're actually getting interacted with 4 hours a day. And that's not including those that are either having laser or shockwave or, you know. So it's hard work. It's not, you just don't run in there, slap a laser or do a shockwave and move on down to the next stall. And our technicians evaluate these horses. We look at them daily, but we do a full evaluation weekly. Every one of these cases get a full, if they're able to trot, they get a full gait evaluation every week, maybe imaging, depending. And so it's, we adapt, we change that, our plan, you know, based on what the individual is doing, you know.
Yeah, and you mentioned orthobiologics, and so how are you melding those into the mix?
Well, I think you know, I'm a little bit spoiled because we've got our own regenerative medicine lab, and so I mean we use allogenic stem cells. You know,
Right.
We've got a donor herd that they produce Cadillac stem cells. And that's one thing that we need to recognize is that not all individuals produce good stem cells. You may collect bone marrow from an individual, expand them over a 3 to 4 week period, and then all of a sudden you get called up and say, well, listen, these things aren't really growing. And so you've wasted 3 to 4 weeks and you don't have really any good viable stem cells. So we've gone the allogenic route. We've tested these donors. We know what their stem cells can do. And so I'll be honest with you, I can inject stem cells within an hour and a half of making a diagnosis. You know, I don't have to wait 3 to 4 weeks. Now, there are some other products out there that are, you know, porcine bladder matrix, placental tissues, etc., that are being used. And certainly you do have PRP that certainly can be. And I'll be honest, I don't use a lot of PRP anymore. The reason being, I found most of your PRP requires 3, maybe 4 injections, whereas stem cells, I can get by with just 1 injection. So I look at a cost-benefit ratio, and I can stick stem cells in at one time and don't have to keep sticking needles in things. And so that's what we do, more stem cells than we do actually platelet-rich plasma. We still use it, but for the most part, we use mostly stem cells, and we certainly use orthobiologics in our joints. You know, we do put PRP in joints. We will, you know, put the autologous conditioned serum or you know ACP, etc., in the IRAP in the joints. We certainly do all that, but again, it's based on what the individual diagnosis is and what the signs that individual is showing. But I like stem cells, and we will actually combine it. I've already mentioned shockwave therapy. Shockwave therapy has a stimulatory effect. It also increases the release of alpha granules from your platelets. So certainly using it in conjunction. Laser definitely has a stem cell stimulatory effect, recruiting stem cells into the area. There's certainly stimulate growth factors, etc. Radio frequency therapy. We use a lot of radio frequency therapy. It again has a stem cell stimulatory effect. So we will use those modalities around the time that we use the orthobiologics.
And are you using low frequency
Ultrasound?
ultrasound? Sorry. Yeah.
We have used it, but I'm more of a fan of the high frequency units.
Okay.
But that's just and we've got a unit. We've got a low frequency unit. Do we use it? Yeah. But I think we probably use our high intensity unit a little bit more, to be honest with you. The primary reason that I use therapeutic, well, the two things I use therapeutic ultrasound. One is prior to exercise, and I'll use it in the continuous mode to generate heat and increase tissue pliability. And that way, be it stretching, be it passive movement, be it, walking in the arena, I'll do the treatment before that. And the other thing is for scar tissue remodeling. I do tend to like shockwave therapy a little bit better for that, but we certainly will use both low frequency and high frequency to work on scarring, post injuries in that more chronic period, just to aid in some tissue remodeling.
And now on your stem cells, because University of Tennessee is unique, a lot of major universities are closing their stem cell labs. Mm-hmm. But Tennessee is expanding theirs. Mm-hmm. And now on your allogenic stem cells, are you using those just strictly in soft tissue injuries, or are you using them additionally in joints?
Primarily soft tissue. Okay. I have not been that impressed with joints, the results. I think I can do other orthobiologics and get as good of results. But I'm really mostly a fan of the allogenic stem cells for soft tissue injuries, tendons and ligaments. Where you've actually got a defect. And that's just kind of what we do there. It's like I said, for joints, I'd rather put in ACP or ACS or even going to your polyacrylamides. It just depends on what you're trying, what the disease process that is going on.
Yeah, I think be flexible and use the tool that's going to help you with it.
Yeah. And you got to think about price too. We deal with a lot of backyard horses, and there are going to be some individuals that they just can't afford it. You go put $2,000 worth of stem cells in something, they say we can't do it. So you have to look at alternatives and come up with a plan that works, that is best for the patient and best for the client.
Well, and I like your rationale, of treating the whole horse. Mm-hmm. And I really believe in that. And, I even our practice, we make sure they go out the door with a rehab plan, a recheck, a corrective shoeing plan if there is one needed. And if the horse is PPID, then we're going to talk to them about that, and
Yep.
that can affect the healing process.
Oh, yeah.
And you've got to, and if the horse weighs 200 pounds more than it needs to, you got to sit there and have an honest talk about, this horse is not going to heal well.
Yep. Yep. Well, and that's oftentimes, and I always, in the talks when I'm giving general talks, you can't get tunnel vision down on the problem. You've got to look at it globally and holistically. And not only, nutrition, extremely important. While we do a good job with nutrition in the clinic, we do have nutritionists that we can consult with at the university, which is nice. But we start out with a base diet, and then we add whatever's needed or take away things. We're big fans of the omega fatty acids for their anti-inflammatories. The other thing is mental. You can't neglect the mental aspect. And these horses need to be interacted with. You can't just stick them in a stall, get them out and do something with them, and then stick them right back in the stall. We put hang toys, we've got balls. Some horses, they need a buddy. You go get them a goat, or you get them a Shetland pony to hang out with them. We've got, what's interesting, we've got a big fiberglass life-size horse. We've actually got two of them, and that are on rollers. We push them all over the hospital to keep individuals company. And it's amazing. I can have a horse over in the rehab center, and they're maybe they're the only one there. I can get that horse, take it over and put them in the stall next to them, stick them out the yoke. All of our doors over in the rehab center have got, drop down doors in the front door. And that horse thinks there's another horse next to him. And it's amazing just that mental aspect of having a buddy next to them. We get horses coming in. Oh God, you can't take them out. They have to be sedated. They've been somewhere, and every time they come out of the stall, they get sedated. Well, we have found that if you interact with these individuals and kind of give them a job, that you can get by with not using trazodone or acepromazine or whatever the case may be, So you've got to think about that mental aspect as part of the holistic looking at it. We're lucky. We've got acupuncturists on staff. We've got chiropractors, so we can address the entire individual and not focus strictly on the injury or whatever the problem is that they're in there for the rehab. So you got to look at the total body.
You got to look at the whole horse.
And you've got, and like you said, what y'all do as far as sending them home, a plan. You need to have a plan, and then, because there's a lot of stuff that the horse owner can do at home if they're instructed properly. And so there's programs out there, to be honest with you, exercise that we use. EQ Active, that we set up a plan, and it will go to the owner, and it'll show videos and how to do specific exercises and stuff like that. It's a program we use quite often for home exercise programs. And so, and then you've got to go back and reevaluate.
Right.
You've got to go back and reevaluate and adjust your plan.
Yeah. Now, I think it's fascinating to me how rehabilitation has changed just through my career. And, I think it's really fascinating for you because you've been at the forefront of that and leading one of the major university programs to it. And so kudos, Steve.
Well, thank you.
I'm a big fan. I like reading your stuff, and I like talking to you about it.
Well, believe me, it's a team effort. It's started at the top with support from administration to build the rehab center, and then support from faculty. And support from our residents and interns and PhD students and master students, and our technicians. You know, we couldn't do it without our technicians, and our vet assistants. You know, I'll be honest with you. It would be cost prohibitive for me to go in there and do every single thing on an individual myself. So we design the programs, we evaluate the horses daily and weekly, and then a lot of times our technicians and our vet assistants, you know, they do the work. You know, they're the ones that have the horses out in the arena working them over poles. They're the ones that are sitting there for 45 minutes with the horse in the treadmill. They're the ones that are doing, you know, a 30-minute laser treatment. You know, it's without the support staff, we couldn't do what we do. You know, they're crucial, and you know, from having
they're the backbone of every clinic and every practice. They're always out there doing it.
I've got one technician that is so attuned to the individuals. I mean, if there's a hair out of place, we get notified, you know, that this has changed. I mean, it may be, well, it's not standing quite as square today as it was yesterday. And they are so attuned to the individuals that oftentimes they pick up things before we do. And so to me, it's critical. To have trained staff, without a doubt.
Well, Steve, thanks. It was a great talk, and enjoyed catching up with you and learning about your exotic career that I had no idea about.
Yeah. It's I dabble around in actually, I've done. Excuse my language. I've operated on ostriches, you know, and back when the ostriches were big, you know, we had ostriches coming in and we did surgery on them. It breaks up the monotony. If you work on horses all day long, it gets kind of boring. So having something to stimulate you, is certainly nice.
Well, thanks again, and
Thank you.
We will see you next time down the road.
Anything we can do.
You bet. ISELP In Motion. Thanks.
Okay. Thank you.